Good evening, everyone. Welcome and thank you for coming. This is our webinar called Best Practices for Health Teams Providing Sexual and Reproductive Care. My name is Morgan Kondratic, and I'm going to be moderating our webinar today. I'm a global health intern at Seeds of Healing this semester, which is an HIV awareness and advocacy organization whose mission is to deconstruct the myths that perpetuate HIV stigma. Our work seeks to eliminate disparities for Black women living with HIV. This webinar is being recorded and will be shared on our SoTime platform and posted to our YouTube channel for you to share with others or return to watch for yourself. As attendees, you can drop questions in the chat box, which will be shared throughout and at the end of the webinar, but these will not be anonymous. So if you wish to ask anonymous questions, please use the Q&A feature. Feel free to ask questions and write comments throughout the program. And we're also going to be sharing a short survey at the beginning and the end of the webinar, so we would appreciate it if you took a few moments to complete it. The purpose of this webinar series is to improve reproductive and sexual counseling skills, reduce preventable health concerns, and expand access to pre-exposure prophylaxis known as PrEP, which is a medication that's taken before exposure to HIV, and post-exposure prophylaxis known as PEP for HIV and other STI prevention after exposure. And we also aim to expand access to reproductive care and learn a status-neutral approach to gathering sexual history and promoting healthy behaviors. And there is going to be a part 2 to this webinar next week on the 29th. So we hope to see you guys there as well. Alrighty. And I'm going to go ahead and let the other interns introduce themselves, and then we're going to introduce today's panelists.
Hi, everyone. My name is Quinn Manley, and I am a public health preclinical intern at the Seeds of Healing and also at Novant Health this semester.
Hi everyone, my name is Molly Phillips, and I'm also a public health preclinical intern at Seeds of Healing in Novant. So before the webinar begins, please welcome our panelists today. We have Dr. Walker Coughlan. He is a family medicine doctor. He attended UNC for medical school, and he is from Wilmington and plans to stay here after residency.
And I will be introducing Dr. Abby Nix tonight. Dr. Nix is from Orlando, Florida, and received her Bachelor of Science in Health Sciences from the University of Central Florida. She found her love for medicine during her undergrad years while working as an EMT. She then attended Edward Via College of Osteopathic Medicine in Monroe, Louisiana, and completed her clinical rotations in Shreveport, Louisiana. Dr. Abby Nix chose family medicine because it allows her to practice a wide breadth of medicine. She is particularly passionate about providing care to underserved communities, women's health, LGBTQIA+, and emergency care.
Okay. Next, we have Dr. Danielle Nerber, who is a family medicine resident at New Hanover Regional Medical Center. She is from Buffalo and currently lives here in Wilmington with her husband and 2 dogs. She is passionate about health equity and serving her community in the best way that she can. And then last but not least, we have Dr. Sophia Theodos, who is originally from the Atlanta area. She has a mini golden doodle named Summer and enjoys hiking, spending time on the beach, and trying new outdoor activities and foods here in Wilmington. She attended Wesleyan for her undergraduate degree and UAB for her master's in public health. After working in Eswatini, Thailand, and Birmingham, Alabama on healthcare initiatives specific to HIV-positive populations, she decided to go back to school to earn her MD to further address the healthcare disparities of vulnerable groups. She loves that her family medicine program at Novant is focused on bettering the lives of all people from a medical standpoint, as well as through addressing education, food security, transportation, and other social determinants of health. And her overall interests include women's health, reproductive health care advocacy and justice, global health, gender-affirming care, and preventative health. So thank you, panelists, for being here tonight, and I am going to go ahead and turn it over to you all.
All right. Well, thank you everyone for joining us tonight. I hope everyone's staying safe and warm and had a good snow day if you were so lucky to have one. So thank you for the wonderful introductions. So tonight's webinar, like she was saying, is the first part of a two-part series on best practices for health teams providing sexual and reproductive care. And tonight we'll be focusing on a status-neutral approach for gathering sexual history. But be sure to tune in next week for our colleagues to be talking about PrEP and PEP as well. All right, so I know they gave us some wonderful introductions with some pictures already, but I just wanted to put our pictures up here, give a little introduction showing that we're from all different years of our training in family medicine. So Dr. Coughlan, myself, Dr. Nerber, Dr. Nix are all in our first year of our family medicine residency. And Dr. Theodos, who will be the mastermind behind navigating our PowerPoint tonight, is in her third and final year of her residency. And I just wanted to briefly show for those who aren't familiar with us, I know there's some familiar faces on here, but some that are unfamiliar, where we work and where our home base is. So majority of our intern year, they're in the first year of our residency, is primarily in the hospital, but our home base is here at Novant Health Family Medicine Clinic in Wilmington. There's our address there on the bottom. And I just wanted to show this because I think it's important to know that we are a primary care clinic that really can provide a full spectrum of care, and we pride ourselves on doing so. So listed there are just a few things that we do provide, all the way from newborn care to pediatrics, women's health, including OB care and family planning, adults of all ages, chronic disease. We also provide HIV and Hep C treatment, gender-affirming care. We have a walk-in clinic for our established patients, and we also provide OMT because we do have DOs in our program as well, which is a type of manipulative treatment for patients with musculoskeletal conditions. So we really are kind of full spectrum, and that's one of the most important things in providing this type of care for our patients. All right, so our objectives for this evening, we are going to start by reviewing the barriers to sexual health. We're going to discuss the status neutral approach to gathering a sexual history. We're going to talk about the 5 Ps, which are ways to help you gather a sexual history for a patient. And we'll finish up by wrapping up and kind of reflecting on what we learned and what we can take away from this evening. So first off, why is this important? Asking sexual history questions can be stressful in general for both the provider and the patient, but mostly the patients. It can be awkward, it can be confusing. Patients can be worried about being judged, stigma. So we really need to make sure that we're doing this in a sensitive way, because the last thing we want to do is cause harm to our patients or cause distrust. Sexual and reproductive health is something that's very important and something that doesn't get a lot of notice because of the barriers that we'll talk about. So this webinar tonight is kind of the first step in doing so, making sure that we as providers, and I see on the poll, we have kind of all spectrum of people, even a patient here with us tonight. So it's just important to be educated on how to do this in a very sensitive, non-judgmental way so that we can reduce harm and foster trust and good relationships with our patients. All right, so what are the barriers to obtaining a sexual health history or providing reproductive care in general? So I bolded this first one here, provider discomfort, because that's kind of the highlight of what we're going to be talking about today in order to help providers do this in a more sensitive and neutral way. But with provider discomfort, it could be ranging anywhere from the provider just thinking, I don't think I really need to know about this patient's sexual health, when in reality, it might be important to the story, all the way to the provider just not knowing what to say, don't want to offend the patient, don't want to say the wrong thing to the patient to prevent from doing harm. Patient discomfort is also a barrier. Patients just feeling awkward, not knowing that they can talk to their provider about this. Maybe they've had a past experience where a provider didn't react in the right way or didn't know how to help them when they shared the concern that they had. So patients just aren't usually going to openly ask questions because of all of those reasons. Stigma, of course, is a barrier, as we all know. Sexual health, especially HIV care, is still very stigmatized in our society. So trying to work on ways that we can reduce that stigma and just make it a normal part of healthcare, a normal part of our clinic visits, is something that we can do to be better at this. Cultural factors, don't forget, can also be a barrier in obtaining sexual health and reproductive care. There's a lot of women around the world who aren't allowed to talk about their sexual health. So it's just important to kind of keep those things in the back of your mind and not just assume that everybody can openly talk about these things with other people in the room or with you as a provider. Lack of services and providers that can treat the problems associated with sexual health can also be a barrier. There might be clinics that can see patients but don't know how to treat HIV, don't have the capacity to test for STIs, and feel like they have to send patients to a different clinic to do so or a different place to do so. That's why I love our clinic, because we are very full spectrum care and can kind of do all of those things. But I know not everybody is lucky enough to be at a place like that. And medical mistrust and implicit bias are also something that we don't want to forget for barriers to sexual health and reproductive health care. Prior history of situations with providers or just the healthcare system that negatively impacted the patient can prevent them from wanting to continue talking about things like this. Institutionalized racism and systemic barriers as well can prevent patients from wanting to talk about this and getting the care that they need and that they deserve. So these are just all things to kind of keep in mind, and things that we can do moving forward to kind of make it a overall easier place for patients to openly talk about their sexual health and for us as providers to ask about it. All right, so moving on to the status neutral approach. So the status neutral approach within sexual health means basically providing comprehensive care and preventative services to everyone, not just HIV positive individuals, but anyone who, just any person, HIV negative, HIV positive, people who are concerned, just regular patients in general. And its idea is that it's a one-door approach. So just one place that you can go to kind of get all the care that you need. And it's a framework in itself that's kind of designed to address institutionalized stigma by, like I was mentioning, integrating both prevention rather than just, you get tested here at this clinic and you have to go on to this clinic and get treatment. And that's important because if you have to do that with your patients, it can deepen the divide between people who are HIV positive and HIV negative and just further perpetuate that stigma, which we don't want to happen, and we want to prevent that from happening any bit further. And just in general, it enables everyone to know their status by making HIV testing available to everybody, not just, again, those who are concerned or maybe think that they have HIV themselves. So I just pulled this from a CDC article that talks about the status neutral approach from HIV. And I just like the image itself because it shows that this is a continuum. Everything is connected. Again, it's not HIV negative individuals, HIV positive individuals. Everybody is kind of connected in this continuum. And again, this is just an approach to kind of promote continual assessment of people's needs, ongoing engagement in HIV prevention and care, including accesses to services including those related to social determinants of health. So I've also pulled this from that CDC article as well, which I can provide a link to in the chat at some point when I'm done speaking. But these are just some examples of some of the states and territories in the US who are using this status neutral approach. So for example, in New York City, they are trying to address the stigma associated with HIV and STIs. And how they're doing this is they rebranded all of their STI clinics to just say sexual health clinics to try to reduce that stigma and make patients feel more comfortable kind of coming in, getting the care that they need. Another example of this, and I won't go through all of them, is in DC. They have also developed a status neutral approach, kind of targeting early intervention services, getting patients engaged in early HIV care. And it's trying to make strides in integrating prevention and treatment services, which previously were operated independently, but this time kind of promoting the whole person health, HIV outreach, education, testing, retention, and care, all of the things. So just in general, the status neutral approach is, like I said, really a framework that encourages comprehensive whole person assessment of each individual's unique situation, allowing for more tailored and frankly more successful interventions. And really, the biggest way to start by doing this is learning how to even get patients to talk about what they need, what their care goals are, kind of meet them where they're at. And the first step in doing that is learning how to gather and take an appropriate sexual history, which is really the highlight of this presentation and what we'll be talking about for the remainder of this presentation. And I will pass it along to my colleague, Dr. Coughlan.
Awesome, thanks. Okay, so the first step, or like kind of the this slide is basically just to say that a lot of people are going to be involved in taking a sexual history from patients, from like people at the front, handing out forms, and maybe patients will ask questions about that. Obviously, like a lot of times, the people actually, like the nurse checking in the patient, will end up asking a whole lot of the history questions. So it's important to make sure everyone in the clinic is comfortable taking a sexual history, because the patient might kind of shut down before the provider even gets in the room if the clinic environment isn't kind of open. And that also includes things like the signs in the clinic and just the atmosphere, making sure it's a welcoming environment. That's everything for that slide. Yeah. And so this is a slide on, gender identity and expression, just as part of making things more welcoming for patients. And so, yeah, just a quick overview that a lot of people probably already know is your sex is like your chromosomes, XX or XY. And then your gender identity is kind of more like, just like it sounds, more what you identify with, whether it's masculine, feminine, or anything in between. And then sexual orientation is more, these are all like, can be separate things depending on the patient. So kind of having a little bit of understanding of this is just kind of part of creating a welcoming environment. That's it for that slide. So we'll start with just a video on like an example of taking a sexual history. And it's basically like the first 2 minutes, Sophia, it'll be kind of obvious where to stop. But the first one's supposed to be kind of bad. So try and think of a few things that you might do better, or things that you think went well too.
Watch as this provider takes a sexual history from a female patient. What do you think the doctor could have done better?
Hi, I'm Dr. B. Are you Sharon Morgan?
Yes, I'm Sharon.
Well, you'd like to be called Sharon?
Yes, please.
Okay. So, what brings you in today?
Well, I just started dating someone new and I'd like to get STD testing done so that I'm good to go.
Okay. Do you know when the last time that you were tested for HIV?
I think it was about 2 years ago.
Did you also get tested for other STDs?
I think so.
Do you have sex with men?
Mostly, sometimes women. I like exploring.
So you're bi,
I guess.
right? So I'm just gonna ask you about condoms. You always use them, right?
Most of the time.
Good. It's good. You mentioned you had a new partner. How long have you been sexually active with him?
Derek, about 3 months.
And including him, how many partners have you had in the last year?
3.
Are you currently using contraception?
Just the condoms. I had taken birth control, but I stopped about a year ago because it made me feel bloated and I kept missing it.
Oh, that's too bad. Have you ever been diagnosed with an STD?
No.
Do you use any drugs?
I smoke cannabis.
How about cigarettes?
No.
And alcohol? Do you drink alcohol?
Socially.
Sharon, any other medical problems, medications you take, allergies?
No.
All right. Well, anything else you want to let me know about?
No.
anything anyone saw that maybe they could have done a little bit better there? You want to like unmute or?
Feel free to add in the chat too as well if that's easier for you guys.
Yeah, the way she said good was really weird. It's like good, that's good. And it also like you're indicating, it kind of implied what the correct answer was. So the patient will probably start kind of modifying what they're answering to give the provider what they want. Yeah, same thing, Dr. DeFelice. Kind of like leading answer or questions. Yeah, lots of like making assumptions. Yeah, definitely like the whole vibe was very very judgmental. Yeah, so oh yeah, one more. Oh yeah, they kind of just like left like some questions like hanging out there. They didn't really get all the information that they needed. And I think they probably just moved on just because it was very awkward. I felt uncomfortable watching that. So yeah, a couple things that we'll kind of go through. I think we can go to the next slide. It's just a little bit of like a framework. Oh yeah, so before that even, just kind of starting off, I don't have a lot of experience with this and I get pretty uncomfortable with it too, but in general, asking patients questions that could seem kind of nosy, I always just like to lead with like why I even care about it. And so here's a couple like ways that you could lead off. In general, I like to tell them like specifically, I'm asking this question because based on your answer, it might change what medications I do or don't offer you or things like that. And there was a USPSTF, which is stands for the U.S. Preventative Services Task Force. They, just like the name sounds, they make various recommendations for preventative services. And they're very conservative on what they recommend. So there has to be like a lot of evidence to recommend things. So in 2023, they recommended offering PrEP for patients that are at high risk for getting HIV. And all the things that they define as high risk are things that you would find out from a sexual history. So like who you have sex with, actually, that can change your risk profile for HIV. Even your gender identity can change your risk profile for HIV. And then the types of sex that you have can change your risk profile too. So that's like the reason to be asking any of this stuff. And so that's how I've been kind of leading off whenever I do ask patients these things or anything sensitive. I think that's pretty much it for this slide. So here's kind of like a framework for thinking of all of the aspects of the sexual history. It's the 5 Ps. So partners, practices, protection, past history of STIs, and pregnancy intention. And we can go on to the next slide. So for partners, you want to make sure, just kind of like we were mentioning with the video, like making sure you get full answers for all these things. So if they say they have one partner now, asking about like if they've had more partners in the last 12 months, how long they've been together and all those things. And again, it's not to be nosy, but just to be able to see kind of what their risk is and if they would qualify for getting PrEP. And here's like a couple different examples of kind of how you could phrase this question to kind of get the information you need. And some of this kind of falls into like practices as well. but like oral, vaginal, anal. Yeah, that's fine. You can go on to the next one. Yeah, so then, yeah, like one other thing, like as far as why you would be asking about their sexual practices, in addition to the guidelines on like offering PrEP or not, is if you are doing like STI screening or testing, it obviously like matters what kind of sex you're having, based on like where you're going to actually swab. And this is just like a whole bunch of examples of kind of how you could phrase this to get a complete history. Yeah, that's pretty much, we can go on to the next one. So yeah, and then asking about protection, it's important to kind of ask, again, this is kind of just goes into like having an open atmosphere and allowing people to feel comfortable telling you like the full story. Because if you ask someone if they use condoms, they could honestly answer that and say, yes, I do, like when they use condoms, a certain percentage of the time, or, very rarely. So you can either just make sure that you're following up and asking, like, how often are you using condoms, or whatever they're using, or just have like a open environment so that they feel comfortable telling you something that they might not otherwise. And then, yeah, also this includes asking questions about vaccinations. Are they up to date on all, like, have they gotten their HPV? Have they, are they up to date on all of their screening, like pap smears, things like that. So that's also something to include under the protection part. And then a history of STIs. Obviously, if there's a current STI that is going to affect, that needs to be treated, but just having a history of STIs also changes, like even if it's, completely treated in the past, depending on what STI they had, it might put them in that high risk category, and then they would qualify for getting offered PrEP. So it's important to figure out, exactly what they've had, if they've had anything. And then if they haven't had anything, it's also important to, see, have they been tested, and that kind of stuff. And yeah, I think we kind of covered all of those. I think that is everything.
Dr. Nix, did you want to take over?
Yeah, I can do the pregnancy intentions one. You can go back.
Sorry, did I skip over yours? My bad.
It's okay. So for pregnancy intention, it's really important to screen them based on what kind of risk factors they have, and if they are currently trying to get pregnant, because that's going to affect if they can use condoms or not. So based on all the information you would have asked previously, you need, if they're trying to get pregnant and they currently have HIV, if they're in treatment, and how they plan to deal with that. Go to the next slide. So some examples of that. So would you like to have children or have more children at some point? And no is a great answer as well. When do you think that might be? Because that affects what kind of contraception we're going to offer. If they just want to, if say they just had a baby and they want to wait the minimum amount of time to have another baby, that's, we're not going to use like a long acting contraceptive, which would be like an IUD or something. So that is a conversation to have with them. How important is it to prevent pregnancy? Some people they don't want to take birth control, but it also wouldn't be the end of their lives if they got pregnant. And some people, they really do not want to get pregnant. So that would affect condom use, that would affect sexual practices as well, and risks of contracting STDs or STIs. Are you or your partner using contraception or practicing any forms of birth control? Basically, you just want to get a clear picture of how they plan to, if they have a plan in place, if they don't want to get pregnant versus if they do want to get pregnant. And sometimes people, they just haven't really thought about it, and that can be a good conversation place to talk about it with people. So then finishing the session, you kind of just want to make sure that all of their needs were met, and make sure you didn't skip over anything, and ask them if they need anything else. And then, yeah, that's really move on to your next session of the interview you're going to be giving during that, like trying to make it as uncomfortable as possible. What Dr. Coughlan was saying earlier, kind of like signposting, be like, hey, I really care about your health. So I'm going to ask you some uncomfortable questions. You cannot answer them. Answer whatever you feel comfortable with, and then ask the questions, and then finish it up, and then continue your session. And the more comfortable the provider feels and looks to the patient, the less awkward it's going to be. So that would be my words of advice. So some examples, just asking overall, like, is there anything else about your sexual health you want to talk about or discuss? Yeah. So yeah, now that we have kind of gone through the information portion of this lecture webinar, is there anything that you guys think you learned today, or anything that you will take away? You can put it in the chat.
Or if anyone even has like personal experiences that they would want to share, of examples of either like good things that providers have done or said, or bad experiences for us to also learn from as well, feel free to unmute or also put in the chat.
Can you guys see what Dr. Dave Felice said? He said phrasing it as sexual health versus HIV care is elegant, or naming places as sexual health clinics instead of HIV clinics. I think that's a good thought, because obviously there's unfortunately still a lot of stigma with persons with HIV, and we don't ever want someone to feel uncomfortable or have any reason to not come. And so I think sometimes even naming like things like family planning clinics, et cetera, things that make spaces more accessible to patients, the more accessible, the better. Any other final thoughts or questions for you guys that we can answer tonight?